Hello, my name is Yejun Hong. I'm a medical student at the University of Calgary, and our team is here to explain chronic kidney disease as a connection between ophthalmology and nephrology. Just like any other organs in the body, the eyes have their own intrinsic vascular system. Therefore, maintaining low levels of toxins and optimum range of osmotic and hydrostatic pressures in the blood is very important to maintain the health of the eyes, especially in the eyes because they are very fine vessels, also known as microvasculatures in the retina. Um, Change in permeability or injuries to such blood vessels can lead to adverse effects in vision. The organs that play a very important role in maintaining homeostasis of the fluid levels within the body is kidneys. The kidneys filter out harmful substances from the blood, just like cellular waste products, and excessive hydrogen ion levels, as well as glucose. By controlling the fluid levels, it also keeps the blood pressure within an ideal range. So, insufficient kidney functions can lead to the fluid and the toxic waste to accumulate within the eyes. So what is chronic kidney disease? Chronic kidney disease, or CKD for short, can occur from various underlying causes and diseases, and we'll explore that in a little bit. And such various causes can result in abnormalities of kidney functions, so the impairment of the organ and of the kidney-related values like the GFR and creatinine. And it receives a special title in its name called chronic because it persists for 3 months or more. And this disease is also defined functionally. So if the individual having these abnormalities suffer significant health and functional implications. Because the retina is the layer of the eye that's most affected by the changes in the vasculature, let's review the anatomy of the retina. When facing straight at someone's eye, you will be able to note the following structures through the fundus exam. The fovea and the macula are located on the temporal side of the retina and has the highest concentration of cones. The light that converges in this area is perceived as the objects in your central vision. On the nasal side of each retina is the optic disc. Optic disc is a point of collection and exit for the ganglion cell axons, and is essentially where all the visual information is collected to leave the eye and enter the brain. Ironically, the light that converges at this spot cannot be perceived by the brain, and therefore it also forms the blind spot. You will also be able to see the vessels of the retina. Both the veins and the arteries pan out from the optic disc and can be seen with the fundoscopy exam. The veins are usually thicker and are of darker color. There are also many retinal layers within the retina itself. To briefly explain a few, there is the RNFL, or the retinal nerve fiber layer, which consists primarily of retinal ganglion cell axons. There are also, of course, ganglion cells, and also the bipolar and horizontal cells. Bipolar cells are interneurons connecting ganglion cells to the photoreceptors. The horizontal cells help integrate and regulate inputs from numerous photoreceptors, and also act to provide inhibitory feedback to such photoreceptors. The plexiform layers consist of collection of synapses among many different cells within the retina. In the inner plexiform layer, the bipolar amacrine and ganglion cells interact via synapses, and in the outer plexiform layer, there is a dense network of synapses between dendrites of horizontal cells and photoreceptor cell segments. Here is the overall cross-section anatomy of the eye, very generally, as well as a close-up cross-section of the retina, demonstrating different layers. So the retinal layers and networks of vasculature can be disturbed by chronic kidney disease. Let's curve back to the CKD and explore what can be the causes of such a disease. And in terms of treatment and also investigating the cause in a structured manner, dividing the etiology into these three categories really help. Pre-renal literally means before kidneys. For example, hypoperfusion of the kidneys or not enough blood feeding the kidneys themselves can impair kidney functions. This can further happen from systemic events such as severe blood loss, low blood pressure, heart failure, dehydration and burns, as well as severe infection and the resulting shock. Renal artery stenosis can also be a cause, and atheroembolic disease that is caused by plaque from other locations, like atherosclerosis, can be another reason. The stenosis and the atheroembolic disease is similar in that the blood flow to the kidney is severely reduced. Some drugs can also have that effect as well. NSAIDs and ACE inhibitors, which are used for pain control and fluid volume control respectively, can cause injury to the kidneys as well via prerenal constriction, or vasoconstriction, I should say. In the renal zone, or the kidney itself, the causes of CKD can arise as well. The renal causes are further split into glomerular and tubular, as well as interstitial. The glomerular causes, like diabetes and hypertension, exert its effects on the glomerulus. This is a complex network of capillaries surrounded by the Bowman's capsule, where filtration occurs for excretion from the body. You can see the glomerulus in the diagram on the right. High pressure from the blood can damage the microvasculature of the capillary system, and the altered level of viscosity from the raised level of sugars and accumulated toxins in uncontrolled diabetes can damage the layers within the glomerulus and change the permeability such that protein-based products within the blood can leak. This includes some antibodies and complement system, among many others, and as they go down along with the transport of urine, they can stimulate a series of inflammatory reactions within the kidneys. After the glomerulus, the filtrates normally goes through the tubular route of the kidney, and this includes the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule, as well as the collecting ducts. The damage in this portion of the passageway can be caused by medullary cystic disease, where small fluid-filled sacs called cysts can form within the salty medullary layer of the kidneys. And also, autosomal dominant or autosomal recessive polycystic kidney disease can alter the tubular system as well. The interstitium is all the areas surrounding these tubules and the ducts and glomerulus that we talked about. And certain drugs and infections can cause inflammation in this area too. Lastly, after the filtrate has been through the kidney, if there is obstruction in the urinary tract after the kidneys, the contents may reflux back into the kidney, and there would be overall accumulation of toxins. You may have already guessed some of the risk factors of CKD. Diabetes and hypertension can be a renal, or more specifically, a glomerular cause of CKD. So individuals who already have these diseases are more vulnerable to CKD. Similarly, CHF or congestive heart failure can become a pre-renal cause of CKD. Anemia is when there aren't enough red blood cells within the blood. So naturally, the capacity of the blood to carry oxygen is more limited. To compensate for that, the heart tends to beat harder, resulting in higher blood pressure. Family history of kidney disease that is observed will put that individual in a greater risk of CKD. And unfortunately, socioeconomic circumstances, or statistically, First Nations populations have a greater proportion of individuals with CKD. The stages of CKD is mainly determined by the GFR of the kidneys. The GFR value is a measure of the glomerular filtration rate, which is the rate at which the kidney filters the blood in our bodies. This is calculated by having a reference molecule in the blood. You can calculate the level of the product in the blood, in the urine, as well as the time to calculate how quickly the kidney is filtering the blood. And such molecules can be creatinine, or products that cannot be altered, metabolized, or produced within the body, such as inulin that will be injected. So according to the criteria for CKD, stage 1 is when there is detectable kidney damage with various means of imaging and investigations, but the GFR is intact. It's 90 or above. Stage 2 is when the GFR is within the 60 to the 90 range, so 60 to below 90. One thing to keep in mind is that it is not surprising for some elderly patients to have a GFR value to be within this range, just because the kidneys have been used for so long. So that goes to show how important it is to interact with the patients and keep in mind the individual variations according to their circumstances. Stage 3A and B are moderate reduction in the GFR. 3A would be within 45 to 59 range, and 3B is between 30 and 44. Stage 4 is a severe degree of impairment of the kidneys such that the GFR is reduced all the way down to 15 to 29, 30-ish range. And stage 5 is a point of kidney failure, or less than 15 units of GFR. This is a progression at which the kidney function is performed at such a low rate that the GFR is minuscule and meaningless compared to the body's needs to excrete substances. So we can consider kidney transplants or hemodialysis or peritoneal dialysis at this point. And the units for the GFR is milliliter per minute per 1.73 square meters. Some of the symptoms and signs of CKD is included in the list below. The degree of each presentation may vary depending on the stage of the CKD, and some of the symptom or sign may not be present. Nevertheless, the common symptoms and signs that are observed in CKD are dysuria, which is pain or discomfort upon urination, nausea and vomiting, fatigue, muscle cramps, and peripheral edema, as illustrated by the bottom right picture over there. CKD is a very broad disease, and there are a whole constellation of symptoms and signs that can occur within a patient with CKD. However, as per the nature of this presentation, we'll focus more on the eyes. Uremia, or having high levels of urea in the blood, or anemia, having low number of RBCs in the blood, can cause optic neuropathy within the retina. Optic neuropathy is damage to the optic nerve, and this can cause dyschromatopsia, or loss of color vision, and loss of peripheral vision, or reduction of the visual field. Cataract can be caused by the deposit of toxic substances on the lens, and the oxidative stress from the blood not being able to deliver oxygen and nutrients properly can lead to neovascularization, and especially if the neovascularization occurs at the iris and blocks the iridocorneal angle, this can raise the pressure within the eye and cause glaucoma. Dialysis, which is one of the treatment options for end-stage kidney disease, has its own risks to the eye. This time, optic neuropathy from ischemia can occur, from hypotension and elevated blood viscosity, as well as glaucoma from the same reasons as above. Altered permeability of the capillary system at the choroid layer can lead to a leakage, undue leakage of the fluids, and lead to retinal detachment as well. Uremic optic neuropathy can include signs such as progressive vision loss and reduced pupillary reactions to light, because the optic nerve is injured and cannot properly respond to light stimulus. As you can see in the pictures, optic neuropathy presents with a swollen optic disc, which is elevated and has blurred edges instead of sharp, clearly demarcated disc. As we have covered before, CKD can be from a lot of different causes, and the diseases that cause CKD effects can vary as well. The differential diagnosis that has CKD as part of its presentation includes a lot of vasculitis, such as granulomatosis with polyangiitis, and rheumatological disorders like lupus. Diabetes can also adversely affect the kidneys by itself in a complication known as diabetic nephropathy, and can lead to CKD. If the presentation lasts less than 3 months, it may be acute kidney injury instead of CKD. And renal artery stenosis as pre-renal cause, and urinary tract obstruction as post-renal causes that we've explored before can be the main diagnosis of CKD as well. When the toiletry in a house is broken down for a very long time, that's going to cause a lot of problems. As such, let's explore some of the complications of CKD. The disease, long-term disease when the disposal system of the body is broken down. Because of all the accumulation of products in the blood, atherosclerosis is a real concern in patients with CKD. Volume expansion, due to not efficiently being able to waste fluid, can lead to hypertension, peripheral edema, and congestive heart failure. Potassium is also excreted mainly through the kidneys, so the impairment of the kidney functions can cause hyperkalemia. In a healthy kidney, the excretion of potassium occurs via aldosterone actions with the exchange of sodium. Cells contain a lot of potassium, so when there is a lot of cell death, a lot of potassium is also released, contributing to the hyperkalemia. Acidosis can also be a problem in CKD, whether by high anion gap or with normal ones. An acidic environment also acts against the crystallization constant of calcium, so it results in bone breakdown. You've also probably heard that lactic acid, upon continuous strenuous exercise, breaks down muscle as well. So skeletal muscle breakdown is also observed in instances with acidosis. Kidneys, we should know, are phosphate wasting machines. So if the kidneys are impaired, there is phosphate retention, and the levels of phosphate increases in the bloodstream. As this helpful flowchart diagram shows, the phosphate and calcium are closely linked inversely to properly maintain calcium levels in the blood. The increased level of phosphate in the bloodstream and the reduced amount of phosphate, therefore, in the renal tubules causes parathyroid hormone release. Parathyroid hormone decreases the phosphate level and increases the calcium level within the blood. That's why PTH is activated when the level of phosphate in the blood is high, because it thinks that it implies that calcium is low, which is usually the case. To make up for that illusion of lower calcium, it breaks down the bone. This adds to the earlier problem of acidosis already breaking down the bone. Kidneys also produce a hormone called EPO, or erythropoietin. This is a signaling hormone that causes increased production of red blood cells. But when the kidneys are impaired, the EPO will not be produced as much, and also the acidic environment of the blood breaks down the red blood cells much faster. The combination of two complications results in significant anemia. And as discussed with the ophthalmic complications of CKD, uremia, or the accumulation of urate in the blood, occurs. To investigate the cause, or if the patient has CKD, we first measure the GFR. This laboratory request, and therefore the value of GFR, is done by using inulin or creatinine, as mentioned before. These molecules are measured and put into this helpful formula, and I won't go deeper into how these formulas are attained. Measuring the serum creatinine can also give an idea of the GFR generally, they are inversely related. And finding the urea level within the blood is also a valuable investigation. The urinalysis and the urine dipstick can distinguish the cause of the CKD. Looking at the urine sodium as well as the different types of casts such as RBC casts, granular casts, and WBC casts, we can generally ascertain if the cause of the CKD is prerenal or renal, and if it's renal, if it is glomerular, interstitial, or tubular. Abdominal ultrasound can also be done to see if there are any masses compressing the vascular supply or if there are any stenosis. CKD treatment is to treat the underlying cause after finding out what's causing it. We should also try not worsening the CKD presentation by avoiding contrast dyes, by avoiding NSAIDs and aminoglycosides, as well as nephrotoxins. For hypertension, ARBs, loop diuretics, calcium channel blockers like diltiazem, and aldosterone receptor blockers, or ARB, can be used. Because the barriers against proteins within the blood could have broken down, and the proteins are getting into the renal system, a reduced protein intake can reduce the strain in the filtration system. Salt restriction is helpful because it reduces the osmotic pressure of the blood to not retain any more fluids. For hyperkalemia, low potassium diet, as well as loop diuretics and potassium binding resins to excrete it through the GI system can be effective. Acidosis can be relieved with sodium bicarbonate. Hyperphosphatemia can be relieved via phosphate binders, and calcidiol and calcitriol can be optional add-ons. Exogenous sources of EPO or ARNESP can stimulate RBC production and work against anemia. For advanced CKD, like end-stage kidney disease, may require dialysis or kidney transplants. Referral to nephrologists is warranted if the disease is acute, the presentation is progressive, if it's getting worse and worse, if the following treatments that was mentioned in the previous slides were ineffective, the proteinuria is persistent, or if when the GFR is less than 30, so stage 4 or 5. And the prognosis of CKD will of course depend on which stage the patient is in. And sooner they receive appropriate treatment and control of the kidney impairment, the better the outcome will be. Here is the review slides from earlier. Hopefully now the connection between the eye and kidneys are drawn, because we've touched on how CKD can have a complication regarding the eyes. Here is a summary chart of everything we talked about. And this is the reference of all the sources of information that we accessed. Thank you for watching this video.